Good afternoon, everybody. We are here for another guest talk by Dr. Willona Annunciation. She's a renowned psychiatrist from Mumbai. She's a consultant psychiatrist as well as a mental wellness trainer, founder of Catalyst Clinic in Thane, Mumbai. She has a passionate professional creating awareness and battling stigma associated with psychiatry. She is an alumni of Grant Medical College and Father Muller Medical College, Mangalore. She is a consultant psychiatrist at Institution for Psychological Health, Thane, and Prafulta Center for Psychological Wellness, Andheri, Mumbai. She is trained in basic and advanced REBT with level 1 certification in Gestalt therapy methods. She is the coordinator at YAMI and OCD support groups, along with providing subsidized services and conducting workshops. And after all, she is my very good friend. And I invite Dr. Willona to share her expertise. Her topic is mental health disorders and occupational therapy, creating magic in functional outcomes. All the students and delegates are requested to be in the auditorium.
Thank you, Dr. Sriharsh, for that introduction. Good afternoon, everybody, and thank you so much for this opportunity to present on this platform. I'm going to be speaking about mental health disorders and occupational therapy, creating magic in functional outcomes. And I am going to speak from the perspective of my experience as a psychiatrist working in the private subsidized setup. For a very long time, from research evidence, from books and various authors that I have been reading, we know that psychiatry and occupational therapy are linked together. We know that a lot of our patients come with an association with a variety of pathological signs and symptoms. Their structural, neuroanatomical differences, for example, anomalies found in the brain, lesions in the brainstem, enlargement of the ventricles, atrophy of the brain, and various minor abnormalities that are picked up on the limbic structure, the cerebellum, and the corpus callosum, keep coming up in the different studies that we see. We also see functional neuroanatomical correlates, so hypofrontality, reduced cerebral blood flow, and challenges in the metabolism in the frontal lobe of the brain, along with biochemical influences with neurotransmitter dysregulations. All of these play a very important role in the organization as well as the presentation of the various symptoms that we see in the clinic, whether it is positive symptoms like delusions, hallucinations, disorganized speech and behavior, or whether it is negative symptoms like restricted emotions, avolition, anhedonia, attention and focus impairment. We see that a number of these concerns keep popping up as we work with patients in the OPD. And while we see these concerns, and I'm going to backtrack to my work during my PG days, where we were taught about the use of medications to manage the neurotransmitter imbalances, but there always seemed to be a gap, because we would manage the imbalances in the OPD, we would manage the challenges that the patient came to us in acute care, but when it came to functionality and outcomes for the longer term, I always came back with what else can we do. And this was not answered during my PG days, because all I studied was from the textbooks and my exposure to occupational therapy was limited. So we know that intensive psychotherapy and OT therapeutic approaches, in addition, has helped much more than medication alone or therapy alone. But that perception and that understanding and that application in private is something that I learned only after coming into the space of working with patients on a daily basis. So what were the challenges that I saw? A significant proportion of people with mental health disorders continue to have persistent and disabling symptoms. Many of them are unable to get their life back on track. Persistent clinical symptoms, disabling medication side effects, inability to hold secure employment, and significant livelihood issues related to their concerns. And of course, all of us battle the stigma, the discrimination, and the social exclusion that comes with our repertoire of disorders. So when I started working in private and I started interacting with some really good professionals in this space, I learned that my patients could be benefited by the addition of psychotherapy as well as occupational therapy. Today I'm going to share with you 2 cases where addition of occupational therapy has really changed the approach as well as the functionality of the patient and the outcome that we are seeing today. The first case study, the patient presented to me in 2019. He came to me in August, accompanied by his mother, a 17-year-old male who had completed his 12th standard. He came with the clear goal that I want to pursue engineering. He had not cleared the entrances, was not able to secure admission in the engineering colleges, but wanted to do engineering because both his father as well as elder brother were engineers, and if he did not complete engineering, then he felt that his purpose in life was not being met at all. The family, the mother and the son came for family counseling to manage behaviors because there were problematic behaviors in the mother. She was struggling with bipolar disorder with a borderline personality, and they came with complaints of severe emotional distress, with extreme mood fluctuations, frequent self-harming behavior, and the self-harming behavior went to an extent where he would almost on a daily basis engage in hitting himself, using various objects around the house to harm himself, injure himself, as well as a lot of destructive behavior around the house. They had visited multiple psychiatrists and psychologists, received various diagnoses starting from bipolar disorder to borderline disorder to even schizophrenia in one of the cases. When I went back into the birth and early childhood, he was born of a full-term cesarean section delivery after a prolonged labor. And the mother reported that there was both delayed birth cry as well as delayed milestones through the process of the child's growth and development. In fact, I remember the mother clearly mentioning that he did not speak at all till he was 4 years of age. Until about 2.5 years, she was feeding him ground up food because he was very, very specific about the kind of food he would eat. He had developed meningitis at 8 months, which was treated, and seizures till 9 years of age. And one of the common complaints that they received from the school as well as from other people who interacted with the child was he would not express sadness or happiness in the course of his interactions with people. All through his academic process, he was average in academics. However, there was a constant self-critical, self-devaluating content of talk. Even in the OPD, sometimes he would hit or slap himself, and there would be episodes of rage with destructive anger. I managed the boy between 2019 to 2020 when he decided to move abroad to study, and we sent him there on medication. At this point of time, he was not taking occupational therapy. Over there, he completely decompensated, had a severe suicidal attempt for which he was admitted in a facility in the US and then finally brought back by the parents. When he came back, after my insistence, we evaluated, did a detailed neuropsychological evaluation including his IQ, and then referred him for occupational therapy. For the last 1 year, the boy has been following up regularly with occupational therapy. And in my last follow-up, the boy actually turned around and said that he's still struggling with his studies. He still finds it difficult to manage the academic challenges that he has taken up. Because given his average intelligence, the engineering studies seem to be quite difficult for him. But the choice that he has made to persist in it, he mentioned that now, even though he is appearing for exams, the amount of self-harm that he engages in, the amount of self-injury that he was engaging in has significantly reduced. So his last exam, he was able to do the exam with distress as well as some support of SOS medications, but minimal self-injury. And this shift has happened only because he continues regular occupational therapy with a therapist who visits him at home. The second case that I have, the patient presented to me in February 2023, 32-year-old male, a BE in computer science, but not currently working. He had difficulty focusing and communicating and said that he was troubled by a paranormal communication. So he kept expressing that someone is commanding him to do some things. He was not able to express how the commands were being conveyed, but he talked about certain movements that were happening in his body because of the commands that were being received. And he was very clear that he could not hear any voices. He was not able to hear any auditory phenomenon, but experienced his body being forced to do certain things. In response to this, he would get extremely agitated, irritated, aggressive, and the family would struggle to manage his behaviors at home. He specified that the entity or the being forces him to do certain things against his will. He was very calm when he explained to me that he knows that it is not logical, but he insisted that that was how it was and that was what he was experiencing. And this paranormal communication had been happening since 2017. When asked what he was doing to manage these communications, he said he uses something called affirmations, which were phrases that he would keep repeating to himself to combat the control by the entity. But given the degree of distress that he was experiencing, he had stopped working, stopped doing anything constructive at work, and would spend long hours sitting in his chair or lying down or walking about, pacing around the house. Even though he was on regular medication, there was no improvement in these experiences that he was reporting. He consulted several psychiatrists and was under treatment with an antipsychotic and an antidepressant when he came to me and was diagnosed as a known case of schizophrenia. There was a family history of schizophrenia in the paternal uncle, with a disturbed sleep, with delayed waking, and substance use before the entity started controlling him. So he had a history of using cannabis as well as tobacco, and he clearly mentioned that once the entity started controlling him, he stopped the usage of these substances. Even on reviewing his medication history, when we looked at the dosages that had been given, even with full dose antipsychotics, there had been no improvement in the psychosis symptoms. And with psychotherapy, we could not find any benefit, as the patient kept refusing that it was benefiting him to any extent and kept saying that he would not continue meeting the therapist. Finally, he agreed to start occupational therapy to improve his functionality and routine. And currently, he follows up regularly for medicines and occupational therapy. Parents report, as well as the patient reports, that the challenges have reduced. They are better able to manage distress, and I am looking at modifying his medication regimen to make it at the minimum possible medication that can be given for the patient to manage his distress best. So in my experience as a psychiatrist, I know that when we use evidence-based occupational therapy interventions, we have seen a definite benefit for patients with psychiatric disorders in terms of engaging in their everyday activities, in terms of managing their leisure, their social participation, and coming to a healthy daily routine. In fact, the process that is followed in terms of engaging them in not only physical activity, but also core strengthening, also bringing in their daily routine functioning, it really helps when we have a team of occupational therapists as mental health service providers in our interdisciplinary healthcare team. So this ensures to enhance, restore, or promote functional performance as much as possible in terms of independence, safety, and quality. We deal with very complex problems of the human mind. And yesterday I had the privilege of listening to Professor Norman Sartorius, who spoke about the changing paradigms in healthcare. I think it's time for us to now look at what we can modify from an individual perspective to help improve our understanding of the complexity of mental illness, increase the repertoire of treatment models that is available to our patients, and liaison with the multidisciplinary team that includes psychiatrists, psychologists, occupational therapists, remedial educators, and psychiatric social workers, so that we can actually practice and not only preach client-centeredness. Thank you so much. I hope my two cases have helped change the way that you all look at the way we psychiatrists also practice. I hope that I look forward to many more future collaborations with occupational therapy and in the broader scope of helping our patients achieve better functional outcomes in the longer run, see a much more collaborative approach towards mental health care. Thank you.
Thank you, Willona. That was a wonderful talk. Any questions from the audience? Okay. Oh, please ask, Samil. Introduce yourself. Mike, please.
I can hear you.
Yeah.
That these ACs can be very much effective in having early developmental disorders and stuff like that. So there was a study in which 12% of children did show in their adulthood some adverse childhood effects, something like that. So is it relevant? Have you been through that research or that aspect, ma'am?
Sure, thank you for that question. It's absolutely relevant because when we are looking at the biopsychosocial model of causation of mental health conditions, we need to understand that there are multifactorial reasons for why patients present to us, right? And we have very limited support to offer them in terms of the interventions that we have. So we need to look at everything that can come into the picture of causation and then see what we can do. For example, if we are working with an ACE from a patient's childhood, we could probably look at trauma-focused work, we could probably look at interventions from the psychotherapeutic aspect to help them work through that traumatic experience for their future. So I would definitely consider that, and I do in my practice take into account childhood experiences. Thank you.
There's one more question from the online audience. This conference has become hybrid. So somebody has asked about case 1, was dyslexia ruled out apart from his diagnosis of BAD, schizo, etc.?
Yes, dyslexia was ruled out. In fact, earlier he had received a diagnosis of dyslexia, but this child had, actually adult by the time he came to me, he had undergone at least 3 IQ tests at different times. The last IQ test that we did, I remember in fact I looked back at the scores yesterday night before the presentation today. So the full scale IQ was around 99 and there wasn't a significant discrepancy between the VIQ and PIQ. So definitely dyslexia was ruled out for that patient.
Thank you so much. Sir, Apte sir. Mike, please. Apte sir is our senior most professional from Ahmedabad who's practicing psychiatry and is recently got the Best Rehabilitation Professional Award by President of India.
I have been working in BM Institute of Mental Health in Ahmedabad as a psychiatric occupational therapist. The 2 cases you represented, I thought you are looking at from the neuro point of view more. But I will like to add that if an occupational therapist works as a group therapy with these patients and with lot of creative activities and creative work, I think these patients can be helped more. Thank you.
Absolutely.
Thank you. I call upon Dr. Sunny Joseph, Organizing Secretary of Oticon 2024, and Dr. Roshan Galvin from Cape Town to felicitate our speaker, Dr. Willona.